Ben and Catherine, we're now moving on to the single oversight framework, which I think is formally for approval. We haven't quite got lots of spare chairs around this table, so why don't you come and just stand here, so at least you can be seen for the benefit of the public and the subsequent viewers of our board meeting. And sorry you have to stand. There you go. I mean, take it that we've read the paper, make any introductory comments you want to make, Ben, and we'll take it from there.
Okay. Well, as you've seen from the paper, we concluded the consultation on the single oversight framework. We got a broadly positive response from the sector, with the great majority agreeing with the overall approach that we're taking. We've made a number of proposed changes following that consultation, which we've summarised in the paper. The main three were, first of all, to give greater emphasis to the autonomy that we're giving to the best performers. And there's some detail in the paper on how we're doing that. The second is to point up more clearly how we're working alongside the Care Quality Commission to align our approaches so that we get ever closer to a single definition of success, so that providers know that they're not being pulled in different directions by different agencies. And the third was to point up what was already, I think, there in the single oversight framework, but the provider sector asked us to draw it out more clearly, and that's that this is all about an emphasis on support. It's about using this as a framework to make a set of judgments that enable us to determine which providers most need support across the 5 themes, whether that's in relation to quality, money, operational performance, leadership or strategic change. What you have in front of you is a revised framework that encapsulates those changes together with 2 specific changes that we made following further policy development. One on the specific metrics used in the use of resources theme, and the second on streamlining the set of metrics used for the quality of care theme. The proposed next step is twofold. The first is to formally introduce this framework so that providers have transparency that this is what we're using from October onwards to make judgments about the support and in some cases the interventions we make. But alongside that, we're also now into the process of testing with providers a shadow segmentation. This is important for 2 reasons. First of all, we obviously want providers not to be surprised by where they end up when we publish the first formal segmentation. The second, it also gives us the opportunity to check that this is working in practice and to iron out any potential wrinkles in the implementation of the single oversight framework. And probably the point I just want to end on is to emphasise that right from the start we've aimed to avoid this becoming a mechanistic process. So there's a set of metrics which trigger discussion within regional teams and in some cases within our central directorates about the support we give. But they are just triggers, and it's what's most important is that people apply judgment in using a range of data, both the quantitative data and local insights, to determine where providers will most benefit, either from our support or from other support that's available from within the sector or elsewhere.
Good, thank you. And there's nothing to add to Ben's, because I know you're doing all the hard work behind the scenes, as you often do, Catherine, which we're very grateful. Question, Sarah.
I wanted just to understand a little bit more. I think you say you've removed some of the quality of care indicators, things like the never events and the SUIs, and I just wondered the thinking behind that and how we're going to be sure that we're not missing anything.
Well, I might actually ask whether Cathy would...
That's a good deflection. Cathy, why don't you answer that?
Okay, thank you. So, when we had a look at those specific things, what they told you in terms of the quality of care in the organisations were in some instances, they were very specific about a kind of point in time, and they weren't necessarily the things that over a more sort of slightly longitudinal period of time were going to be the correct things. We're very much trying to align with the CQC, so we've got very much using a single framework in that respect. What of course we want to ensure is that we're not completely reliant on a CQC's assessment, because we've got the time in between. So we've boiled it down to the set of things that you see in there, but that doesn't mean that in a day-to-day interaction with organisations we won't be looking at a range of other things just in that normal sort of discussion. So it's been discussed across the clinical teams and so on, and this has been the agreement of where we've got to.
So to the extent that an organisation has a rash of never events or serious incidents or whatever, is that now only picked up at their own board levels?
No.
Or else does it get picked up?
No, that's also every week that's collected and shared with us, and I think Ruth and I both get a readout of that, and the patient safety team, which is a substantial body of people focused on safety, keep a track of that. And therefore that drives some of the support and improvement that occurs to help organisations that are maybe not quite got everything, in terms of human factors and other things in place to deal with that. So it isn't as though we're not looking at those, it's just that in terms of determining where they are in this framework, it isn't a good indicator.
If I may just follow on from that, just to emphasise the point, across all of the single oversight framework, we've identified a limited number of measures, and those are the measures where we think there's greatest value in us overseeing the sector to identify particular support needs and where potentially we think that there is greatest scope for improvement. And that leads to this segmentation idea, which will influence the type of relationship and the level of support that we give to a provider. But it's only a means to an end, and it's not everything that we do. So it's just one tool in our armory.
Other questions? Ara?
I'll come back to that safety thing at a later stage, because I think that's important. Great to achieve better alignment with CQC, but why is it not the same? Why didn't you just go and push them a bit harder and say, this is it?
In our consultation response, we set out, I hope more clearly, how in most respects we align exactly with the work of the CQC. The three current differences are, first, that we have a theme that's just about operational performance. In other words, how well organisations are meeting the NHS constitutional standards. That's not inconsistent with CQC. What's different is that it's a theme in its own right. And it captures different elements of the CQC's questions about whether services are safe, effective, caring and responsive. We felt that given our particular responsibility to support the provider sector in meeting those NHS constitution standards, which are so important for patients, we should have a theme that focuses on that. The second thing we've done is to have a theme that's just about strategic change, or to be more precise, the contribution that a provider organisation is making to developing and implementing transformation across a wider health economy, looking beyond their individual organisational parapets. That's implicit in some of the CQC's questions, but it doesn't have as much prominence. And given the vital importance of the work that providers are doing with other providers and with commissions and with local authorities on things like sustainability and transformation plans, we felt that again that deserved a theme in its own right. And the only other difference is one that will we think fairly soon get eliminated, and that's that, of course, at the moment the CQC don't assess finance or use of resources. So we've had to develop our own finance and use of resources thing, but we're now working with the CQC, using that as our starting point to develop a shared approach which they will then reflect in their overall ratings.
Great answer, but I just think, why should we have a single oversight framework? Bits of it we will have more interest in, bits of it they will have more interest in, is the question. I fully understand where you're coming from, that obvious that we may not be.
That is still the aspiration. That is what we are working towards.
It's just about PSR and getting from where we were to where, I think that's definitely where we want to be.
Yeah.
But the risk involved with too quickly going there whilst trying to unravel from the old systems. In spirit between us, across both organisations, that's where I want to be.
It's a journey.
Good.
Yeah.
Hopefully a short one, but it's a journey. Sigurd, and then we'll...
Where in all this do we have an opportunity to take into account the context in which the individual organisation finds itself? We know from earlier discussions that in the 44 STPs, for example, there are some where collaboration is going really well, the work is advanced. There must, I assume, be individual trusts we're looking to put into one of these categories, where the trust itself is doing fine, doing everything we want them to do, but where the local situation that they're working in is difficult. How do we build that into this?
We try to account for that in two ways at least. One is in coming up with the themes. The fourth theme in the ordering that we've listed in the strategic change is explicitly understanding the context in which they work, the local health economy, the way that the STP is working, and so on. So that is a formal factor in our consideration that we consider alongside the other aspects, the other themes that we've identified. And the other way of looking at it is, as I hope comes over in the document, we use data to give us an initial indication of whether or not we think there are any support needs. And then after that, there's a lot of application of local intelligence for our teams who work alongside providers and really understand both the providers and the environment, the local health economy in which they're working. And so they can use that data intelligently to understand, is there a support need, and in which case, is it a support need for the provider itself or something we need to do in the wider local health economy.
So that comes in under the fifth heading, then, leadership and improvement capability.
It also comes under that.
Good. I sense that the board are supportive of the direction towards the single oversight framework. I've said to Jim and the team that pivotal to its delivery, though, is a strong relationship management mechanism throughout this organisation, through the regional directorate, and one which balances support with clear holding to account against the framework. So it does require a little bit of an organisational development inside our organisation to make sure we have that strong relationship management aspect to our organisation. Can I take it that within that context that the board are supportive to approve this single oversight framework?
Absolutely.
Good. And thank you for the hard work that's been done.